Oh, dear colleagues, my talk today is based on my experience from 2 neonatal intensive care units. One in Turku, Finland, where I have my position, and the other one from Uppsala, Sweden, where I worked last year. And one of my tasks there was to help with NAVA ventilation. In Turku University Hospital, we started with NAVA almost 3 years ago. And in Uppsala, it was started from the beginning of last year. The experience we have as a number of patients, you can see here. So you see increasing numbers, and this last cell here indicates the number of patients during the first 3 months of this year in Turku. Now we have 6 ventilators with NAVA option. So my question is, and I really enjoyed the previous talk, how to implement NAVA, how to change clinical practice, and I have some similar aspects in this presentation. It is not easy, that's in common, to change the clinical practice, and it may not succeed from various reasons. And to understand why and how we could make their success more likely, it's good to understand their different factors that play part in implementation of research knowledge. And this theoretical background I have taken from Alison Kitson and others, and I will go through these 3 main elements of implementation of research knowledge according to parish framework. And when we do changes in patient care, we hopefully base those changes on evidence. And in this case, we need to look the evidence broadly, as we have heard, and we all agree that we don't have enough those clinical studies with real hard, strong clinical outcomes. We don't have randomized clinical trials or meta-analysis on NAVA use in neonates or in adults either. And that is what we all agree on. What we have, however, is a theoretical background, how this is more physiological way to give ventilation support. And here I would like to make an analogy to synchronized IMV. When it came, we switched to synchronized IMV from IMV, as there was no reason not to synchronize the ventilator breaths to the patient breaths. And here I could argue that I see no reason not to use a more physiological ventilation mode if I have that available. Other type of evidence is clinical experience, which also it is good, but it is only from few centers. And as far as I understand and what I have understood today, we don't have a consensus. We don't have good enough clinical experience that we had yet formed the consensus. Then I would like to really talk about this third type of information, which is patient preference, which we can't ignore here. Our babies notice the difference. When they are on NAVA, they are more comfortable and they sleep better. And our parents, they are very intimately involved in the care, as you saw in the pictures. They know what is better for their baby, and they see it and they have their opinion. And I think it is of value itself that the baby is comfortable, even if we don't have long-term hard data advantages. If the babies don't have higher IQ at school age, they are on ventilator, many of them for weeks and some of them for months. And it does matter what's the quality of life during those months. If we strive for patient-friendly care and family-centered care, we can't ignore the comfort of the patient. In fact, it should be the priority in our care. Our intensive care, it doesn't need to be hostile as it was described this morning. I think we have to wake up and see that it's so much up to us if intensive care environment is hostile or not. It shouldn't be. To make it clear to everybody, I'm a very big supporter of evidence-based medicine, and I do clinical research to provide further support for clinical practices. I think these different types of information, they are not mutually exclusive, and it's likely that they will support each other. But today we are in a situation that we have to make a judgment call and choose the way of ventilation when we do not have these hard data from the research side. When we do the judgment call, and we have made the judgment call to start using NAVA, there are factors in the unit which facilitate their implementation or make barriers. If we work in a unit which has continuous learning and continuous quality improvement culture, it is easier to bring something new, a new technique. And here I think family-centered care culture where the staff has a routine to observe their babies and they are listening to the parents, it's quicker and easier to take NAVA in use. Of course, if the ventilator is familiar as it was in Turku, it is easier to just add a module to a familiar ventilator. And as was also discussed in the previous talk or talks, clear roles, clear leadership is important, and teamwork is important. In both of the units where I have worked with NAVA, nurses are adjusting ventilators according to doctor's orders, which means that in training, both nurses and doctors need to be trained simultaneously. And the larger the staff is, of course, the larger the effort of training needs to be. And one context factor is measurement, which was now discussed in this discussion. It is of benefit if the unit has a routine to measure their care practices like ventilation support, when the unit can document the implementation and the impact of the implementation on patient outcomes. And in units, I think it should be an obligatory part of preterm care to follow the long-term outcome. And when you have that as a routine, you will get one day the feedback if your changes are to right direction or not. There are good international quality surveillance networks. The largest one in neonatology is Vermont-Oxford Network, which includes more than 800 units, more than 50,000 very low birth weight infants per year, which collect data on modes of ventilation and lung outcomes. This is an example of steroids use for lung disease, chronic lung disease. And I wonder if we could convince this network to add NAVA use as one item in their data collection. We would very quickly get very nice research on the impact of this ventilation mode on short-term outcomes of infants. That could work as a platform for such studies. The third main element, which was discussed more in the previous talk, is a use of a facilitator, a key user or expert user, and that is something that is regarded very important in adult learning. Adults learn by doing with support, and these key users are staff members, respected staff members who have good teaching skills, who can teach in a supportive, flexible, empathetic way, their colleagues, and who are present. Here, it is a question of teaching skills and also question of teaching a new way of thinking, as we need to think of ventilation differently, and we need to learn a new way to think when we start using NAVA. In our unit, one way to do this gradually and smoothly and flexibly was that we started NAVA initiations were done only daytime when the key users were present before the whole staff was trained. We trained in Turku 3 nurses and 3 doctors who trained the rest of the staff. And initially we got support from the manufacturer, so we had also external facilitators, which was very helpful, but that needs to be replaced by internal facilitators who stay there and carry on the training. In Uppsala, we made a pocket guide for doctors for on-call duties, which was received positively. So does NAVA implementation succeed? When we started to use NAVA, we started to get clinical experiences from parents and babies first. Babies were more comfortable, they slept better. Parents started to like that mode of ventilation, and in Uppsala, where we had only 2 machines to start with, they were kind of keeping tight, that they don't want to give it away when they had got that opportunity to use NAVA ventilation. We got feedback from clinical data. We started to see normal ventilated babies. We had chosen for the last 10 years permissive hypercapnia strategy to avoid hyperventilation, which is very dangerous for the brain of a preterm infant. And now when the babies started to regulate their ventilation themselves, we started to see stable CO2 levels, and mostly normal ventilated babies. We started to regulate our thermostat here in the brain to a different level. And this, we know that both hyper and hypoventilation, and especially fluctuations of PCO2 levels, are harmful for the brain of a preterm baby. So this has a potential to be brain protective. We also saw that the peak inspiratory pressures came down about 50%, and that has a good potential to be lung protective. We have a feeling that we have had maybe a handful of patients who had got dexamethasone before NAVA period. And that is a drug which is known to be neurotoxic, but we are forced to use it when we get in an uncontrollable lung situation. Now the babies were comfortable on ventilator, and we could wait longer for spontaneous recovery, and we think that some of the babies had got this toxic drug without NAVA. But when I look at the statistics, I can't yet prove this in numbers. When I looked at the use of dexamethasone in very extremely low gestational age infants, prior to NAVA, it was, or these years here, 25%, and last year, 22%. So we need time to see if that is really a considerable change. Now I come to the challenge slide. We have challenges, and we wouldn't be here if there wouldn't be any challenges. And the biggest challenge for me is the cost of the catheters. And I looked how many catheters we bought last year. It was 160 catheters, and it's not cheap. And for economical reasons, we have limited the NAVA use for those who are ventilated more than 1 day. For 1 day, we think it's a too big investment to use an eddy catheter. Most of our babies are extubated within 24 hours. Another concern I heard from Uppsala was that they were worried that the babies are so comfortable on ventilators that they don't have any rush for extubation, and maybe the babies are now longer on ventilator. And that is not what we want. So I looked our numbers if I need to be worried in my unit about this, and we can't see here any trend that the ventilator time in very low gestational age infants had gone up. This is the median days on ventilator in this group of patients. But this is one concern we need to be aware of, that we remember to extubate the babies. But if we hadn't succeeded in our implementation, we wouldn't have worries about cost of the catheters or too comfortable babies on ventilators. This baby is holding tight on her eddy catheter. Thank you for your attention.